Welcome to Grand Rounds. This is May 2021. Today we have Dr. Amber Cunningham talking to us about conquering pediatric potty problems. Dr. Cunningham is a graduate of Widener University's Institute for Physical Therapy Education with a Doctor of Physical Therapy. She is board certified in pediatric physical therapy, and she also completed extensive pelvic health coursework and is now working on enhancing pediatric pelvic health services in the Miners and Manhattan region. She has provided pediatric physical therapy in both medical and educational environments, including Children's Hospital of Philadelphia and St. Luke's University Health Network. These settings include school systems, outpatient hospital-based clinics, inpatient rehabilitation, and acute and intensive care settings. Since joining St. Luke's University Health Network, Dr. Cunningham is focused on pediatric pelvic health and POTS. She's committed to enhancing access to specialty physical therapy in Carbon County. If you're completing this for continuing education or CME, please make sure that at the end of this you complete the quiz on my e-learning that will be emailed to you when you are, or that will be activated once you complete this course, and you get a notification that the course is done, set up in my e-learning. And if you're watching the recorded version, you're already in my e-learning, so you'll be able to access it there. So without further ado, let me turn it over to Dr. Cunningham.
Thanks, Stephen. All right, so today we're going to be talking about potty training and conquering pediatric potty problems. This is the St. Luke's Designation Statement. This is the activity description and target audience. And I have no conflicts to disclose. And then here are the learning objectives, so what we'll be talking about today. All right, how did we get here? Why is a physical therapist talking about potty training? So pelvic floor therapy has become a growing specialty of physical therapy as awareness of pelvic floor dysfunction continues to grow. In the St. Luke's network, there are 11 physical therapists seeing patients for pelvic floor related impairments, which is amazing. In the St. Luke's network, there are 5 therapists seeing children for various pelvic floor conditions, mostly dysfunctional voiding, in which the muscles that control the outflow of urine or stool aren't fully relaxing, causing urine retention or other symptoms. Providers send these patients to our offices to work on pelvic floor flexibility, relaxation, and voluntary coordination of this muscle group. But meanwhile, many of our therapists, especially our OTs, are also seeing children for potty training. And this might be due to difficulty managing clothing, understanding a bathroom schedule, practicing hygiene, and working on interoception, or our body's internal awareness system. Now, what we often find in our pediatric population is that in many of these cases, there's also some sort of behavioral training that does need to occur in conjunction with our therapy interventions. The goal of this presentation is to offer a brief description of micturition and defecation physiology, potty training methods, readiness, skills involved in potty training success, and at the end we will go over a case study. Now, I often tell parents when we're discussing a treatment plan for their child that it's not often one isolated system or intervention that when we address will achieve the child's goals. Normal bowel and bladder function and continence require a synergy of body systems and behavior. So developing a treatment plan to approach delayed potty training, it often requires peeling back the layer of an onion in a way. We look at one or more areas at a time while we encourage intervention and change. Now, I think it's vital to our client's success that we take all of these systems into consideration and discussion when treating bowel and bladder dysfunction in a child who's not potty trained. But we need to recognize that when we need to refer and to collaborate with experts in these specific areas. For example, we might be trained in recommending a healthy level of fluid intake based upon a child's age and weight. However, it is important to discuss this with the child's care team because providing too much fluid could cause hyponatremia. It's important to get a good food and diet history, but when a child's diet is so limited that they're not able to consume a healthy balance of soluble and insoluble fiber, among other vital nutrients, discussion with our care team may warrant evaluations with a feeding specialist and a nutritionist. Oftentimes we're seeing children who have ADHD and anxiety, and if they are established with a developmental pediatrician, they're often set up with counseling, medication, and even wraparound services. And it's important to collaborate with everyone in this child's team to establish the best behavioral plan to meet their needs. Now, most importantly, in this care team, we put the child and their support system as the center focus of these discussions. I always say that when we meet the child and that we will meet the child and family where they're at. So if they're not able to manage big changes at once, we take small incremental steps, and that's okay. Now, on this slide, we're going to go over bladder anatomy and physiology. So this is just very general, if you're not a pelvic health therapist, just to kind of give you an idea of some of the things we're talking about. So some basic bladder anatomy. Most importantly is our detrusor muscle. So this is the muscle that controls storage and the outflow of urine. So it's composed of mostly smooth muscle fibers that are both longitudinal and circular. Next, we have the internal urethral sphincter, which controls urine outflow and storage. And this is not within our conscious control. And then the external urethral sphincter, we can control with our pelvic floor muscles, as well as involuntarily. Now the urethra, obviously it's going to be longer in a male, and they'll also have a prostate, but that's more likely to contribute to voiding dysfunction later into adulthood. Now there's lots of central mediation and going on here with our nervous system. Oops, sorry. So basically there's a very careful balancing act with various peripheral nervous system activation and inhibition going on. But to keep it super simple, when our bladder is filling, we call it the filling stage or storage, the sympathetic nervous system is causing the detrusor muscle to be relaxed while the internal urethral sphincters contract. And the external urethral sphincter can be contracted with voluntary control. And during the voiding stage, so urination, the parasympathetic nervous system is at play. And at that point, the urethral sphincters are both relaxed and the detrusor muscle is contracting. So there's just a very basic rundown of storing urine and urinating. Now, the nervous system, when controlling bladder storage and voiding, it's mediated at S2 through 4. So if you remember from anatomy, S2, 3, and 4 keeps pee and poo off the floor. It's kind of a good little mnemonic to remember. And again, we have the sympathetic versus the parasympathetic nervous systems working in this very careful balance. Now, when it comes to bladder fullness, a mature bladder is going to feel full about halfway full. That's the first desire to go. And then at 3/4 of the way full, you get a strong, uncomfortable urge to urinate. In an adult, that's about 400 milliliters, while the bladder can hold about 600 milliliters. Now, while it can hold that much, it is normal to leave some urine behind. Just know that children's bladder capacity is not this high, and children may not reach adult bladder capacity until their late teenage years. Next, we're just going to talk a little bit about bladder development. So in the newborn stage, babies are voiding frequently. Their empty bladder is actually in the abdomen, whereas as an adult, your bladder falls into the pelvis when it's empty. And their bladder capacity at birth is about 10 milliliters. That increases to about 60 milliliters at 9 months. And at 1 to 2 years, children are becoming more conscious of bladder filling and they're gaining more voluntary sphincter control. Now, the age at which children gain volitional control is going to range from 5 months to 6 years. So post-void residual volume is going to decrease over time, and it demonstrate large variations as bladder control improves. A normal post-void residual in a mature bladder is less than 50 milliliters. So this is the amount of urine, again, that's left over when you're done going, while children should have a post-void residual of less than 20 milliliters. Now, acquisition of bladder control is mostly cultural. So these timeframes vary largely based upon various cultures, and voiding never happens during quiet sleep. The bladder fully wakes up the child as they experience cortical arousal. The child then voids. Here on the right, I have a picture. This is a diagram of what providers would look at when it comes to a uroflow study or uroflowmetry. This measures how much urine passes, the flow rate at which it passes, and the length of time of a void. So this is might be used in combination with pelvic floor EMG and a bladder ultrasound for a post-void residual. And it can assist providers in diagnosing an overactive bladder, dysfunctional voiding, underactive detrusor with abdominal straining, or bladder outlet obstruction. Now, oftentimes, I might have kiddos who they're going to the bathroom multiple times a day because they're just so busy that they don't want to stop playing. So they might know enough that they need to go to the bathroom. So they run in, they sit down, they pee just enough to kind of get rid of that strong urge to urinate. They don't fully empty their bladder, and then they get right back into what they're doing. So sometimes I'll draw a picture like this just to show them this long kind of peak and then flow of what a urine flow might look like, and I'll have them put it in the bathroom. So when they're sitting on the potty, they can kind of start peeing and follow with their eyes as they reach max flow rate and as it starts to slow down, so that way it can help them visually fully empty their bladder. All right, so moving past the bladder, we're going to talk about the bowel. So a little bit of bowel anatomy and physiology. Now, bowel function is a complex process. It involves colorectal mobility, the enteric nervous system, which is why sometimes nervousness causes diarrhea, because those systems are so interrelated. It involves the autonomic nervous system and smooth and striated muscles. Now, a little bit of anatomy. So here we have the small intestine. The small intestine meets the large intestine at the ileocecal valve. Stool is going to pass slowly through the ascending colon, and then it picks up speed a little bit as it moves along the transverse colon, the descending colon, the sigmoid colon, onto the rectum. And then here's a nice picture. These are the rectal valves. So we kind of have these two major valve systems here, the ileocecal valve that lets things in and out, and also the rectal valves. Now, defecation is initiated when a colonic mass movement continues to the rectum and it distends that rectal wall. So when this happens, it's something called the rectoanal inhibitory reflex is going to cause the internal anal sphincter to relax. And then here's a picture here of the internal anal sphincter. And then the anal canal pressure is going to drop while awareness of liquid, solid, or gas occurs. So there's a reflex called the stool sampling reflex, and then that's kind of what's going to tell us, is this liquid, solid, or gas, so we can prepare accordingly in a normal bowel function. Then the rectoanal excitatory reflex is going to cause the external anal sphincter and the puborectalis to both contract to maintain continence. So here's the external anal sphincter, and then you have the puborectalis here, which is the sling muscle. And that's kind of what's going to keep a kink in the rectum, so stool's able to be maintained in the rectum unless you want to relax that kink and pass a stool. So two things can happen at this point. Either you do nothing and the urge subsides, or you proceed to the toilet if it's convenient. Now, an issue that we have especially with children, is stool withholding. So what can happen is a child might experience a painful bowel movement at one point, and then they kind of remember that, even if they're babies, and they might start to withhold their stool and not respond to those cues. And what happens there is that reflex that tells you it's time to go, it starts to get dampened. And when we don't respond to those urges, the rectum can become more distended as stool builds up, and that further adds to the cycle of dampened reflexes and stool withholding. So what happens next when you do decide it's time to go? Defecation requires the appropriate positioning. So ideally, we want to keep the hips flexed more than 90 degrees to help relax that puborectalis muscle. And then we need our feet to be flat on a support surface. So often this isn't the position for children. So we'll talk a little bit later about some positions that can help with kids. Now, the abdominal and rectal pressures are going to rise. The internal anal sphincter relaxes. The external anal sphincter and the puborectalis relax, which are under our voluntary control as well. And then rectal pressures are going to rise above anal pressures. At this point, the pelvic floor distends and the anal-rectal angle widens. Stools pass, and the external anal sphincter, internal anal sphincter, and puborectalis are all going to contract together, and that's a reflex called the finishing reflex. So that's just a little bit about the process of bowel movements. So moving on to our next slide, we're going to talk a little bit about development of getting to that point of 1 stool per day, which happens typically after 4 years of age. So typically babies are pooping 2 to 3 times a day, a little bit more for breastfed babies, and then gradually over time that comes down to 1 time a day in most kids. Now training. So toilet training is shown to accelerate dryness. There are many methods out there. We won't go over all of them today. Child readiness is the #1 indicator for success. And what I think is the #1 tool in toilet training is that nothing about training should ever be punitive. Training should be reward or intrinsically motivated, so praise and escalating rewards are most important. Now, we must teach bladder fullness, so it's important, when you're training a child, not to have them go just in case. So they might be on a schedule, at which point it is important to go on a certain schedule. But, if they just went potty a half hour ago, but you're leaving to go to the park, you don't really want to have a child go just in case, because they're not learning kind of when to respond to a bladder fullness sensation. Now, studies say there is no detriment in initiating toilet training early. So keep that in mind, because toilet training programs are kind of all over the map when it comes to ages and readiness. And also, we try to avoid saying accidents. So sometimes it requires a little parent training because it's easier to say, oh, your child had an accident. But what I like to say is exactly what you observe. So, oh, your bowel leaked or your bladder leaked. And then instead of, anything disappointing or punitive related to bowel or bladder leakage, you want to praise dry pants. So make a big deal about dry pants. And then another top note on training is that girls do tend to be trained 3 months before boys. All right, so types of training. The child-oriented approach was developed by Spock in 1968, and it starts when a child shows signs of readiness, which we'll get to on the next slide. It is recommended by the American Academy of Pediatrics. The next one that we talk about is elimination communication. So in many cultures, babies will learn to be potty trained by using this method, and it is gaining more traction in the US. And with this method, basically parents are learning their baby's innate cues for voiding, and they use small potties and containers to help their babies void. There's no praise or reward system, and some babies with this method are diaper-free by 6 months. Now, Fox and Azrin studied adults with developmental disabilities in institutionalized setting. They used very structured potty training schedules. They used various types of reinforcement, including positive punishment and overcorrection of accidents. These methods aren't used so much today. However, positive reinforcement and other components are still used today in some ABA settings in order to train children or adults with developmental disabilities. Now, the one-day method assesses bladder control, physical abilities, and the ability to follow a sequence for readiness. It has a strict approval process and they have you increase fluids for successful opportunities to void. And then the child-led method, it starts around 18 months of age when the child shows signs of readiness, It starts with fully clothed potty sits and then moves toward removing diaper, and it's most like that child-oriented approach that we talked about earlier. Now, a take-home on types of training. Praise and positive reinforcement along with child readiness are the most important aspects of any training program. Increased sit schedules and consistency with method that you choose are also important for success. So I do have concerns for using negative feelings or negative punishment toward potty training, especially because it can cause stool withholding or toileting refusal. So again, instead of saying, oh, you had an accident, we want to say, what happened? Okay, your bladder leaked, and you want to be pretty indifferent about it. All right, so those signs of readiness. This is a checklist, but not every box does need to be checked before you initiate toilet training. So a few things here: having bowel movements around the same time each day, no bowel movements at night, dry after a nap, so their bladder control has kind of improved, that they're able to hold their urine for a couple hours at a time. The child can climb and squat. The child's able to manage fasteners. Again, I would say some of these are not required to start training, especially because if they're not yet able to manage fasteners, you can adapt and use elastic waistbands. The child's able to pull down pants or underwear. Emotional readiness, noticing when the diaper is wet, dirty, and pulling at it, kind of using these gestures or cues to inform their caregiver that they're not comfortable, they're aware of being soiled. If they're hiding when they're going to the bathroom, and then interest in the potty. And I would say another sign of readiness that it might be okay to start toilet training is that the child has regular soft bowel movements. So if they are constipated, if they're having, small hard bowel movements, and you can explore, whether or not your child is constipated with your provider. I would say it might not be time to start toilet training until they're able to get into a maintenance program for constipation where they're having regular soft bowel movements. And regarding emotional readiness, so oftentimes, especially in older children, you want to see, do they have an emotional stake in toilet training? So if they're younger, they might be showing more autonomy in their lives. They might want to be more independent or use the potty like an older sibling. And if they're older, they might become more distressed about peers, embarrassment. They might want to participate in activities like sports and sleepovers. So they just might have a little bit more of an emotional investment. And at that point, it's a good time to make changes. All right, so a little bit about developmental concerns and potty training. So in this cohort study, they looked at children who had a diagnosis of ADHD and children who had a diagnosis of constipation. And what they found is that 10.3% of kids with functional defecation disorder and had ADHD, and they found that 22% with a known diagnosis of ADHD also fulfilled the criteria for a functional defecation disorder. So having trouble pooping or constipation and ADHD are pretty closely linked, and oftentimes these are the kids that we're seeing in PT and OT for delayed potty training or difficulty starting potty training. Now, children who have autism spectrum disorder are often toilet trained later than their peers. Children who have autism disorder often require 1.6 years of toilet training to stay dry during the day, and sometimes more than 2 years to achieve bowel control. And I think this is really important to point out because it's a marathon, it's not a sprint. The one-day methods might not work for these kiddos, and it's important to give parents the expectations that, if they're not potty trained in a week, they're not doing anything wrong. Just keep at it and be positive, and over time they'll start to do better. So children who have autism spectrum disorder especially benefit from an approach that includes the following factors. So we might have to look at alternative communication. So how can they communicate their needs, and how can you communicate their needs to them? I think here it's so important to work with their speech therapist to make sure that we're using the proper methods of communication, whether that's a certain process or step in verbal commands or using alternative communication practices. Now we might need to look especially at adaptations for dressing, using visual schedules, keeping a very consistent routine, giving consistent and immediate reward system, and setting small and incremental goals. All right. So we're going to get into habit training. So if a child isn't meeting, that long checklist, like maybe they're really not able to hold their bladder for up to 2 hours, or they don't have an emotional stake, or they're younger and we want to give them a little bit more time to develop, it's never too early to start habit training. So habit training might look like anything that just introduces them to the idea of using the bathroom, using the potty. So you might change their bathroom or change their diaper in the bathroom and have them wash their hands at the sink. You might let them watch their parent or trusted adult use the bathroom so they can see what it might look like. You might let them sit on the potty with clothes on if they're not interested in trying a potty sit with their pants pulled down. And if you sense that the child might be about to have a bowel movement in their diaper, you can move them into the bathroom. So you might not be, putting them right on the potty, especially if they're not ready, but at least they know the bathroom is where I go to the bathroom. Now, if they aren't able to tolerate even wearing underwear, you might just start with, hey, let's do this for a few seconds. Here's an immediate reward. And then tomorrow we'll try it for an additional 30 seconds. And you give them, those clear expectations and lots of praise. And again, when you're training a child or doing any habit training, you want to use clear and simple language. So, hey, we're going to change your diaper in the bathroom, or we go potty in the bathroom, we wash our hands in the bathroom. So nice, clear, consistent language. All right, so we're going to go through a few kind of areas of, I guess, developmental systems that are involved in potty training. So the first one we'll talk about is gross motor. So it's important to state that pediatric physical therapists have an important role in the promotion of fitness, wellness, health promotion, and prevention for children of all abilities. Now, no matter what setting these children are coming from, they should be screened for gross motor delay. And a quick screening for skills that a 5-year-old, for example, might be able to do would include having them stand on one foot for up to 5 seconds, imitating body movements, alternating their feet when going up and down the stairs, climbing on and off furniture, climbing on a jungle gym and ladders, pedaling a tricycle, kicking a ball forward, throwing a ball overhand, catching a bounced ball, running around obstacles, jumping 10 times in a row, and even jumping over an object with their feet together. So frequently I'll ask parents, like, tell me what they like to do at the park. Will they climb on things? Do they prefer to sit down and play? How do you feel like they're keeping up with their peers? This might be for kids who parents aren't coming with a concern for gross motor delay because they just might not be aware of what their developmental milestones might look like. But it is important to screen these kids. Now, it's very important to address these issues, especially when you're seeing kids for potty training or pelvic floor disorder, because a child, for example, who has developmental coordination disorder, they might be less likely to engage in gross motor play and recreation. They're more likely to have obesity, and we know children who are obese are more likely to have fecal incontinence than their peers. We also know that kids who are delayed in jumping by 5 years are more likely to have low self-esteem around peers and more difficulty with sports-related activities. And bringing that all together, kids that are bullied are much more likely to have incontinence. So addressing gross motor, participation, bowel and bladder, kind of in any setting that they're coming into is really important because it affects all areas of their life sometimes. All right. So now we're going to move on to fine motor very briefly. It's definitely not my area of expertise. This is when we talk to our OT friends. But I do want to ask parents about fine motor control, dressing, managing buttons, fasteners, and zippers. If there's still something they're working on at home and in therapy, you might want to adapt by using pants with elastic bands during potty training periods. And you definitely, if they're not already working on this, or have seen someone to, get some tips and tricks or formal therapy, you might need to refer them to get additional help with any fine motor issues. Next is sensory. So when we see children with known or suspected sensory disorder, it's important to explore if children are over or under responsive to various stimuli. So oftentimes they might be hypersensitive to things like sounds or the tag in their shirt, but they might be under responsive to things like bladder fullness. Now, I'll occasionally use a weighted blanket in therapy for calming in order to initiate therapy with some of my kids who have a hard time focusing, and they need to kind of regulate their system to be able to participate. And then this picture here on the right is a Sensi's pillow. It has a gentle vibration effect, and I can use it to gradually increase sensory input. So they sit on it and it gives them more sensory awareness to the perineum. Sometimes it's too much and they don't like it, but it's also something that I oftentimes see kids not like initially, and then over time they tolerate more and more sensory information to that area of their body. So we might have them sit on it while they play a game or a puzzle, and if they tolerate 30 seconds on the first day, they might tolerate a little bit more time gradually. Now, if you're not sure what a child's sensory needs might be, you can have them evaluated by a pediatric occupational therapist. They can administer a sensory profile, and then together with the family, you can incorporate a patient's specific sensory diet into their potty training program. All right, next part of potty training importance is breath control. So a therapist may also work on breath control to improve pelvic floor mobility and to normalize proper breathing mechanics for a pressure system supportive of pelvic floor relaxation and contraction. And you don't just do this laying down like my picture on the right, or the left, I might start there, but gradually we get them in sitting positions or potty posture positions. I might have them work on blowing a pinwheel or using bubbles, especially while in the bathroom. It can help their pelvic floor relax. It can also give them something to do to increase, their tolerance to their potty sit. And this is something I pretty much would never neglect if you're doing pelvic floor rehab, and especially if you're working on potty training. If you're not a pelvic floor therapist and you're not sure what's going on in the pelvic floor area, it's still really important to work on, because that it's going to help promote pelvic floor distension and relaxation when they're using their diaphragm properly. All right, so moving on to what a pelvic health specialist might do to help kiddos gain continence. So pelvic floor exercises may start in a supine position on a mat, with the therapist supporting them to avoid any compensatory muscle use. And then as they begin to have better pelvic floor awareness and coordination, the exercise might increase to sitting on a physio ball, to being in a potty sit position, and even to standing. All right, so in this study by Sadian, pelvic floor exercise with Swiss ball combined with behavioral urotherapy. So urotherapy would be things like fluid monitoring, bowel and bladder diaries, education on diet, education on timed voiding or urge suppression if appropriate, all kind of falls under the urotherapy headline. So in this study, it was shown to reduce the frequency of urinary incontinence. It was shown to improve post-void residual, and the severity of constipation in children with dysfunctional voiding was also improved by using these exercise techniques in combination with that urotherapy. All right, so here's a picture here, just kind of a general top-down view of the pelvic floor muscles. So we talk mostly about the external anal sphincter and the external urethral sphincter, as well as that puborectalis muscle. But the pelvic floor works in conjunction with a large group of a large group of muscles that helps support, stabilize the pelvic organs and they work together, especially when you're doing these pelvic floor exercises. So if one muscle is relaxing, we hope that the rest of them are relaxing, and that's something that we might be working on through, flexibility and breathing exercises in children. So some of these important muscles are a group of muscles in the pelvic floor called the levator ani. And again, what's not pictured here is that puborectalis muscle, which is so important, when it's time to have a bowel movement. All right, so a little bit more about what a pelvic health specialist might do with children. So this is a picture here of some biofeedback. So basically the child is playing a game, which we'll have a video of in a minute. And then we can see on a different screen, which you can see to the right, kind of exactly what they're doing. And so these electrodes are placed externally on their pelvic floor, close to their external anal sphincter. So it's recording some information in microvolts. So you can see on the right, I have a chart here. And now this child is being asked to contract in the video game. So they're being asked to engage their pelvic floor muscles here. And then they're being asked to, then they're being asked to relax their pelvic floor muscles. So you can see he's getting he's trying really hard. So he's getting sporadic pelvic floor activation, up to 3 microvolts, I would say, consistently, which is very low. We want to, and this is in a supine position, we'd like to see them, closer to 15 microvolts in a standing position to show good pelvic floor strength. And then when asked to relax, he's actually doing pretty decent. This was his first time, so he's pretty weak, but he was able to briskly de-recruit the pelvic floor and briskly recruit. He just isn't getting that nice high amplitude and consistent contraction. He's kind of going up and down. So we've got some work ahead of us when it comes to strengthening, but gradually as he improves, we'll change positions and change activities and make it a little bit harder over time. All right, so here's a little video of another child that I have doing biofeedback. She's pretty much done biofeedback. We've moved on to other things. So she actually looks pretty good here. Now in this video, she's being asked to hold for 10 seconds and to relax for 10 seconds. And she is sitting up. So here she's engaging her pelvic floor. She's just trying to keep it over those, I call them space rocks, so she can score points. And now it's telling her to dive. So she's relaxing her pelvic floor. She's de-recruiting. She's turning those muscles off to relax. And then you can see on my screen that, exactly what she's kind of doing there. So she's getting good recruitment, a nice straight line almost. She's holding it pretty well above that goal line of 10 microvolts. And then I cut the video short, but when it's time to relax, again, she has pretty good de-recruitment. That line doesn't trail off, it kind of goes straight down. And then this is another game we have, and in this activity, she's being asked to contract pretty quickly. So this is kind of those quick, strong, forceful contractions that you would get when you need to cough, or maybe, you have a strong urge to urinate and I want them to, sit, do a couple squeezes before they go over to the bathroom to prevent any leaking. So here you can see she's kind of going right up and then dropping right off, which is good. And this was at the end, so she's getting pretty tired, so she's not quite hitting the goal, but she's getting close. All right, so a couple other things we might do in PT. We would observe their perineum. We'd check for skin condition. We would see that their pelvic floor is moving in the correct positions when they contract, both voluntarily or involuntarily, when they relax, and when they bear down. We might also do some reflex testing during these observations. Now TENS, I've only used a few times, but there's some pretty good research out there to support using TENS in children with overactive bladders. So that it can help with that kind of sacral nerve stimulation to help calm that bladder muscle. We'll do education. So oftentimes we'll fill a balloon with water and I'll use my fingers here to pretend that they're the pelvic floor holding the pee in and the pelvic floor relaxing to let the pee out, and kind of what happens when you don't relax fully, right? So you might get that trickle or you might not fully empty. We use Play-Doh, we use Putty. I use a little toy potty to have the kids kind of show me what their poop might look like, so I can, that they know that it should be soft and not hard, etc. All right, and then here is a picture of the squatty potty for kids. So we want them in a nice supportive position. We don't want them feeling like they're going to fall in the toilet, or they're not going to be able to fully relax those pelvic floor muscles. We want their knees elevated above their hips a little bit, and we also want them to be able to, keep their knees apart and have their hips abducted a little bit as well. So they're nice and relaxed and nice and supported. Here's a frog pose. I use that a lot. Just to promote pelvic floor distension, mobility, to kind of give them more sensory input to their bottom. It's a great pose, and it is studied for kids as a program for kids who have functional constipation. All right, a couple other tricks of the trade. I do lots of coloring. We color pee, we color poop, we might color the potty. We might use social stories so that they can understand kind of the process of using the potty, as long as it meets their age and their developmental needs. I have this book, What is Poop? It's a flip book, so it allows us kids to, engage with a book so they can see that all animals poop, what it looks like, just to get them comfortable with the idea, because oftentimes kids are kind of skittish about their poop, and they don't want to talk about it, especially if parents are skittish about poop or grossed out by poop. I try to get everyone in the room to calm down. When it comes to poop, it's no big deal and everybody does it. So that's why we use lots of illustrations and lots of books, just to make them more comfortable about the whole process. Alrighty, a couple other tricks. So you can have a child sit backwards on the potty, especially little boys. If they're a little more comfortable going that way, they just might feel more supported and more stable. A potty sit should be frequent and regularly scheduled. So if you're having your patient do a potty sit, you want to make sure that they're on a schedule that's going to be successful for them. It can't be kind of like once or twice a day. If they're in that formal potty training sequence, it needs to be pretty regular so they get the idea, and so they're more likely to have success and they can benefit from that reward system that's in place. Now, ideally, you would have a child sit on the potty 20 to 30 minutes after a meal, and that would be the best time to capture a bowel movement, because there's something called the gastrocolic reflex that occurs after a meal that makes having a bowel movement just a little bit more successful. Now, oftentimes I'll get parents who are like, oh, they went pee, I promised them, a trip to the zoo in 4 weeks. So I always say that's a great promise, but they need a reward immediately, especially in those early stages of potty training. So praise and reward should always be immediate. They should always be consistent, and that way, especially our kids who have some developmental delay, they can best associate the activity with the reward. And then rewards can also be graded. So you might be rewarding potty sits just for sitting on the potty, but when that becomes regular and not so big of a deal anymore, and they're doing their potty sits with no problem, then the reward may be giving just with voiding on the potty, or even telling a caregiver that you need to void with whatever communication system that you're using. You may also give praise to other members of the family for going potty. So if you're telling big sister, like, great job on the potty, they might associate like, oh, big sister does it too, and she gets praise. So, it's something I want to do as well. Now, even if a child doesn't use the potty, you want to have them complete their potty sit by washing their hands, just to complete the carryover of those techniques, so they know that, if they're not interested in washing their hands, regardless of whether they go or not, they still got to wash their hands. Now, carrying over the same exact techniques at school and home, and keeping the communication with school teachers and all of the child's caregivers is vital, right? Like, we don't want to use different reward systems or different communication styles in different settings, because they're going to be less likely to carry over the positive behavior with the reinforcer. So routine and consistency are so important. And when a child has a hard time generalizing the potty between different places, especially, our kiddos who might have autism, you might need to have a consistent factor. So maybe they use the potty with the same caregiver at the grocery store that they use regularly at home, or they use the same visual schedule at school that they use at home. Now I have a picture here of a visual schedule. It may need to be individualized to the child based on their needs. So a task analysis might indicate that maybe they can independently initiate using the bathroom, but they're not able to sequence pulling up their pants afterward, or using the right amount of toilet paper, or remembering to flush and wash hands. So they might be independent in voiding on the potty, but they're really not independent yet in their potty routine. So again, you can individualize that to the child. And working with speech and OT, I'm sure they have a lot more resources at their disposal when it comes to those types of task analysis. So here at the bottom is a picture of Whiz Kids. So this is basically some colored droplets you can put in the potty just to get kids interested in being in the bathroom. Obviously, if they want to touch the water, not good for that kid. But if they know better that they shouldn't put their hands in the potty, you can put those colored droplets in. There's stick and aim, so some stickers that can go inside the potty, especially for boys, to help them have a target and make using the potty a little bit more fun. For our kiddos who might have an auditory processing disorder, or they struggle with loud noises, an automatic flusher, in a public bathroom is torture. They're not going to want to use the bathroom. So, even if they don't normally use noise canceling headphones in their life, you might want to keep a pair for when you're out and about, just to help them get through using the potty in other environments. And a good old pack of Post-it notes put over a sensor in a public restroom can help to prevent the toilet from going off, especially when the child's on the potty. So just a couple other tricks for our kids when you're out and about or when you're home. And now we're going to go over a case of one of the children that I saw a few months ago. So he was followed by his developmental pediatrician, 7 years old, and he was seeing OT for emotional regulation, toileting, and self-care. He was also followed by various GIs for constipation. They had tried multiple toilet training methods and schedules, so behavior charts, punishment, encouragement, immediate treats, letting him buy his own underwear, avoiding watch. They tried a bunch of different things and nothing seemed to do the trick. Now he would oftentimes use the potty to have a bladder void if he was completely naked at home, but anytime he was wearing clothes, he wasn't able to get to the potty on time, or to kind of be aware of that it was time to go. He was having 1 to 3 bowel movements a day, not consistently the same time of the day, would sometimes skip a day, and he was on Miralax and X-Lax for constipation, but not currently because he had been taken off of it. So gross motor wise, he was a W sitter. He had impaired postural control in sitting and standing. His gait was significant for in-toeing. He had been a toe walker, but this had improved. And he had an increased forward lean when he was cued to squat. He was able to complete multiple sit-ups without compensations, and a Superman pose for more than 10 seconds. Now his flexibility was normal, with the exception of some hamstring tightness and calf tightness. His neuroscreen was normal. Sensory-wise, he had high intense reactions to otherwise low-grade bumps or bruises. So mom would say, like, his brother would bump him and he would get very upset by something pretty low grade. And then in abdominal exam, he wasn't distended, and I didn't see any diastasis recti, which is something we watch out for more in boys, but something we still look for. It's not just present, after pregnancy in women. All right, so we developed a plan of care, and we set some goals. So basically, we wanted him to decrease his urinary leakage by 75%, decrease his fecal soiling and incontinence by 75%, and also to have appropriate pelvic floor awareness. So I gave him some surface EMG goals. Other goals were that he would be able to describe normal frequency and patterns for voiding, because he is a little bit older, that he'd be able to self-manage his symptoms with his schedule, and that his fiber and fluid intake would be identified as appropriate for his age. All right, so we headed off into week 1. Basically, his homework was diaphragmatic breathing, bubbles, pinwheel. I gave him some frog squat exercises, fluid and fiber. So there were some handouts provided, some education, just for mom to think about these things. I think the number one thing was that we didn't get into any schedules because he'd done schedules. Clearly there were other things that we could do before heading back into schedule. All right, so week 2, he did biofeedback. When observing his perineum, he had fair voluntary contraction of his pelvic floor. He had poor voluntary contraction. Oh, I'm sorry, I wrote this incorrectly. He had poor voluntary pelvic floor contraction with poor endurance, but he had fair perineal descent and descent bearing down. So he was able to bear down pretty well, but he really didn't have a good strong contraction and he wasn't able to hold it too long. And it was noted that he did have fecal leakage that he just wasn't aware of. He really didn't have the sensory awareness when he would have a bowel movement. Now his pelvic floor relaxation on surface EMG was pretty high, so he was kind of resting at 3 to 4 microvolts, and that was after lots of breathing and lots of practice. And he was able to contract up to 20 microvolts, but very poor endurance, and I suspected mostly some overflow and muscle compensation going on. So he kind of improved even during the first session with his coordination and his awareness, which was kind of fun to see. We worked on the Sensi's pillow just to improve his awareness to his pelvic floor. And again, we worked on diaphragmatic breathing, but we did some weighted breathing. So I put a weight on his belly and then removed the weight to get him really engaging that diaphragm. All right, so week 3, we did some interoception activities with a body chart where he'd identify what certain things feel like. We did a heart rate game where, he might do jumping jacks. We'll take his heart rate and we'll document it, and he'll describe how he feels when his heart rate is high or how he feels when his heart rate is low. We did some biofeedback with some games for endurance and for those stronger, shorter contractions. And then his homework was pelvic floor exercise, where mom might observe his perineum to see that he's doing a good job. All right, so week 4, he had some potty success that week, so he initiated a bowel movement on the potty on his own, so we were really excited for him. We continued to use the Sensi's pillow. We worked on potty posture. We worked on single leg balance to get the pelvic floor stabilizers kind of working for him. And then weeks 5 through 19, we just continue to progress his pelvic floor or his biofeedback into more functional positions. We worked more on gross motor and just general core activation, stabilization. And at this point is when we started with potty sit schedules and using positive reinforcement. So mom was able to identify some good external reinforcement for him that was motivating. And I did forget to mention, emotionally, he was becoming more aware. He didn't want kids to see his pull up, so he was getting like a little bit more emotionally kind of invested and ready for some change, which was sad to hear, but good for the next step of potty training. And one thing he was working on through these weeks was independence with wiping. So he preferred that other people wiped him, but by week 19, he was independent with doing this on his own. And then we continue to have fluid and diet check-ins and I Love You massage for constipation. All right, so week 20, he continued to do a great job. Biofeedback was pretty much normalized, which was great. I did suspect some ongoing kind of issues with constipation, so I did ask them to go back to GI just to kind of see if he needed to be on a maintenance schedule, but otherwise he was really doing a good job. We didn't need to use all 20 visits. We ended up using 18, but we made a plan to return in the future if any sort of regressions were to occur. All right, so that's mostly the end of our talk on potty training. These are some resources you're welcome to check out. I think the Autism Speaks website has a ton of great resources for potty training children who have autism. And then some references you're welcome to review. And finally, some pictures of my favorite little potty users. So we work and live in the anthracite coal region, and these are pictures from our last trip to the number 9 coal mine in Lansford, Pennsylvania, right up the road from our Nesquehoning therapy clinic. All right, if there's any questions, I think you can direct them to the chat. What's that? Oh, or you can ask through this Teams technology.
There were some comments in the chat about a lot of kids like to talk about their poop, but I guess in your patient population that is not necessarily the case.
No, I agree. My 3-year-old loves to talk about poop. Everything is poop, poop, poop. But in a lot of our kids who might be older, I see that they're more skittish about having, talking about their poop, looking at pictures, or and I'm not sure exactly what the cause is, but it's definitely a barrier in some cases.
Thank you very much for your talk. If anybody would want to contact you for further questions, would you be able to give your email address just out loud?
Sure. If you have any questions or need any resources, you can email my work email. It's amber.cunningham@sluhn.org. All
Awesome.
right.
Does anybody else have any further questions? All right. Well, like I said earlier, make sure you fill out all of the, answer the quiz questions and fill out the course review. And if you have any further questions, please feel free to contact us. Thank you very much.